Welcome to the Sparked podcast, the show that will get you fired up about standards. On today's show, we have Adelaide GP and ex-president of the Federal AMA, Chris Moy, as well as Victorian GP obstetrician Rob Hosking, who's assisted an incredible 1,500 women in their giving of birth. By the end of this episode, you'll know much more about the history and current context of clinical workflows and how Sparked is set to improve experiences for clinicians. Let's get into it. I've got Chris Moy and Rob Hosking. Chris Moy in Adelaide and Rob Hosking in the western suburbs of Melbourne. Rob, nice to have you both here.
Thanks so much, Brett.
We'll be talking a little bit about Sparked and as it relates to clinical workflows, information sharing between health sectors and the clinician experience overall. I think fair to say issues close to both of your hearts.
That's I think why we probably both got into it.
Terrific. All right. Well, I'll dive in. Chris, as a GP and a shy and retiring fellow, I may struggle to get your frank and fearless opinions here, but let's see how we go. Taking your clinical lens, tell us a little bit about the history of interoperability in Australia and how we've landed with the current state.
I mean, in the 30 years I've been in general practice, we started with paper and we've had to sort of evolve into using digital health systems, computers first up. And general practice was very much at the beginning of it. But what became really obvious in Australia is that as a country, we've been very much one that supported things like free market innovation and competition. And that has been helpful in developing key systems, for each clinician, each health organisation like my practice or each hospital. But what has become obvious over time is because of that reluctance to over-regulate, because we want to encourage innovation. But what we realise now is that the inability to get us to work together is as a result of the fact that there's an incentive to try and work in silos in terms of health IT systems. And that really became obvious in the COVID end of things. And we really realised that we needed information at the point of care very quickly for knowing things like whether somebody was immunised and up to date with their COVID vaccinations. And now we've got a different lens now that we really do need to get these systems to start working together so that we can transfer information between them. I realised even in last week how much of every single consultation I spend trying to find the information I need to provide care for my patient about things like what their medical history is, what tests they've had done, what allergies they've got, and also spending a lot of time trying to find workarounds to send accurate information to somebody else that might need it another time. It's such a big burden on care. And the key now to improving healthcare is to try and speed it up, make it accurate and fast so that I can provide care effectively to each patient in front of me.
So we really had 1,000 flowers blooming over a long period of time, which was great to fill the field, but the ability to all work in concert was constrained by that huge diversity and the lack of information sharing between systems and between data sets.
There really has been this incentive to compete. We can talk about various areas, things like secure messaging. That's been good for innovation for each individual system, but not so good when you want to get information from each individual silo. So if I need information from the hospital or the pharmacist, it hasn't been helpful for that because each of them was using a different system and the information was trapped in each silo. There's been a realisation from all the providers of health IT systems that the next stage of innovation will be built on the ability to actually get that information and then evolve their systems to make it faster for us to get that information to the point of care so that we can make it easier to provide care, but also, frankly, make my job a lot easier.
Terrific. Thank you. I'm going to let my dog out and then I'm going to ask you a question, Rob. So, Rob, as a practicing GP obstetrician, have you got any personal examples of how optimised information sharing between health sector results in better patient outcomes?
Yeah, I think reiterate what Chris has said already. It's every day, every patient, pretty much. Anyone who's had any contact with any part of the health system, people assume that we've got the information shared already and can't understand when we don't. In obstetrics, as you said, I used to do a lot of actual intrapartum deliveries, so I managed my own information then, but now I do a lot of shared care. And shared care with hospitals is challenging because of the lack of ability to share the information. We write requests and pathology and ultrasound reports and copy them into the hospital, but the information doesn't flow the other way. But when it does, it's so much better that I can actually be on the same page with the woman who's sitting in front of me who has recently been diagnosed with hypertension, and they've done a whole batch of investigations and they've copied me into those results. Then I'm able to provide her with the right advice on what medication to use and then how to adjust the medication, because they've also told me what medication she's on. So, that's a huge example. Another example is at the other end of the life spectrum in nursing homes. Our local nursing homes have moved towards electronic charts from paper, but the medication charts until only very recently were paper, and they had to be faxed through when we needed to make an adjustment, or I needed to go out to the nursing home just to write up a medication that I could have given a verbal order in a written form in another way. But now we have dial-in to the nursing homes to be able to update their medication charts. They're still not interoperable with our existing systems, but they're way better than they were, and it's resulting in patient care improving very quickly. People in nursing homes don't have to wait for a GP to come out and write up the medication chart or figure out who's got a fax and how we can send these faxes flying around with illegible writing on them. And believe me, it's still happening all the time. It's just, like Chris said, we've been softly with the let 1,000 flowers bloom, but it's time to get tough. And there's been discussion about axing the fax and making that illegal to use. That would be a good idea and push people to using other systems. But we need really good other systems in place to replace those things.
Oh, the dreaded fax sends the shiver up our interoperable spines. Chris, any critical examples that come to mind for you?
It's all about workflow. Rob has emphasised that. And it's about workflow to me to get that accurate information quickly and to be able to send that information quickly in an accurate form as well. Now, like the other day, I'm trying to find a result. It hasn't been sent to me. I'm trying to log into another system, can't log into it easily. And that's taken, 10 minutes out of a 15-minute consultation. And that's trying to get a pathology result, for example. We did a time and ocean study recently to look at how long it took for me to send information. And there was a comparison of secure messaging versus faxing. And the difference is somewhere in the order of about 20 seconds versus 10 to 15 minutes in terms of searching and all the work that's required, not just by me, but the staff at the front of the practice. This really eats away 10, 15 minutes of a 15-minute consult. It means that I, first up, am not providing care. I'm actually trying to find workarounds to find and send information. But it also means I've got no eye contact with my patient who thinks I'm not connected to them. And also I'm not actually using my brain to actually do clinical work for that patient to add value to the consultation at that point. So really what we're trying to do is convert the time we're spending trying to find that information and to send that information into actual care for patient, looking at them, connecting with them, finding out what's really going on and actually converting that into clinical care. That's the big journey to try and make that seamless, not just for me, but I'm talking for every clinician so that the finding of information and sending information is seamless so that they can just provide care to the person in front of them.
Chris, you talked about not having eye contact in a clinical consultation. How does that play out? What does it mean for the patient and for you in that 15 minutes?
If in 15 minutes, if I'm spending a lot of time looking for information or trying to compile the information to send to somebody else and then trying to find a way to send that information, I'm looking at my computer. I'm not looking at the person who's sitting next to me and they're just looking into space or looking at me wondering what I'm doing. And what it means is I haven't done the connection part of the clinical consultation. It's the most critical bit because it means that first up, the person feels that I've connected with them, have empathy for them, have heard them, have understood them, and also that when I'm providing information that I've spent the time to actually look at them in the eyes while explaining something to them. If I'm looking at my screen and not looking at them, it is fundamentally undermining the patient-doctor relationship. And the person may walk out wondering what's happened. They think it's not an actual consultation or an interpersonal relationship, which it should be for it to really work. We talk a lot about the art of medicine, but the art of medicine is based on connection, proper history taking, proper examination, proper consultation and discussion with the patient to come up with the plan moving forward and making sure that they walk away with that information.
Rob, when it comes to safety and quality, there are lots of risks that can emerge in general practice clinical work. and maybe obstetrics in particular. Is there anything that comes to mind in terms of what you think interoperability can do for that safety and quality space?
I think it's a lot about what Chris said. It's about efficiency and timeliness, and then some things become time critical. And when we're talking about time in general practice, it can be a matter of days before you can get information that makes a difference to a patient. For example, being discharged from hospital, we haven't received the information that we need. And in that discharge, the patient has left the hospital. There were instructions that we were supposed to do things, and we have no idea what we're doing or what we've been supposed to do. There's lots of evidence that transitions of care between facilities, hospitals, primary care, nursing homes, that's where the incidents occur, where you get lack of information or the wrong information, resulting in poor patient outcomes and poor quality care. And people get readmitted to hospital or die in nursing homes because they haven't received the appropriate care that was intended and it wasn't communicated, and there was no useful way of the receiving clinician to know what to do and how to manage that transition of care. And that includes also with pharmacy, medication management changes, people coming out of hospital and on different doses or medication that should have been withheld, but they go back to their normal medication. There's lots of examples of those critical incidents. And, medication safety is one of the big pillars of where we could make a difference there.
And now it's time for a fun fact from Kate.
A data group is a standalone content specification about a single clinical concept which focuses on the structure of data and the relationships between data elements. It incorporates codes or value sets from a terminology system as appropriate, and we have 14 data groups that have been defined so far, 10 in AU CDI and 4 in AU eRequest DI.
Yeah, so it sounds entirely like eminently avoidable adverse outcomes. We're really talking about tragedies that don't need to occur in many instances. Chris, can I ask, in terms of what an optimised experience for clinicians looks like, how do you think it can actually be achieved?
Well, it really is actually trying to find every little barrier that affects us in getting that information or sending that information a day. Really trying to isolate it out and actually then trying to work out how we can smooth that out, bridge the gap so it becomes automated and not become part of my workflow. I work in a 30-person practice, and I can tell you that every single day somebody will complaining about how difficult it was to find a bit of information and how the system's hopeless and also how much time it took to send a bit of information and how it's all hopeless. We have this chance now within the Spark program for clinicians to become involved, to try and smooth that out, to become a part of it and actually improve this. And what we need is for people on the ground like myself, but a whole lot of other people who really have day-to-day troubles, who get frustrated every day, become more cynical every day about the system because of it, to become a part of this and actually turn that cynicism into action so that we can actually make it better for them and make their lives more enjoyable while they're providing care for their patients.
And Rob, how do you think Spark as an accelerator can help enable those outcomes, and why should other clinicians get involved in this effort?
Well, the Spark program really does underpin a fantastic opportunity to achieve interoperability by using standards that have been developed in Australia and adopted internationally, and now they're finally coming back to Australia. And if we can implement this, it will make a big difference, as Chris said, to everybody's workflow, but not just the opportunity for workflow, the opportunity for clinical decision support to be built into systems that can help make the right decision and not repeat things that have been done elsewhere. If we can query things across the system and say that, well, I'm going to organise this test, but hang on, it's already been done last week at another facility and here's the result. So many of us worked so long dealing with the frustrations that Chris and I have dealt with that people just accept it as part of the job, and they don't realise how much better it could be if we could have this instant communication across the whole health system around the patient, not around the system, not around the institution, but around the patient, so that if a patient turns up at X facility or Y facility, they've still got the same information at that patient's fingertips for the clinician involved to look at them and make a decision. And to do this, though, further to your question, we need people to be involved. We've got a really great team through the CSIRO Spark program of some clinicians. We've got a great team of developers. We've got government funders in the room. It's actually a fantastic opportunity where everybody's participating, and every clinician who has been involved that I know of has been quite excited to say, I thought this was all nerdy techo stuff, but it's actually not.
Indeed. And Chris, for those clinicians who are a bit reticent about diving into the nerdy techo world, what do you say to them about what they can offer in terms of their real-world experience in helping to design and inform the interoperability journey that we're on?
For many of us, our hearts have been hardened over time about our cynicism over health systems, partly because of this siloed approach to development and also the feeling that only the experts were creating this, that were too smart for us. But what we really realise now is what we need to do is actually start to build both the data and also the technical standards to try and get our systems to work together, stop that friction that occurs to try and find the information and send the information that really eats away at you every single day. And it's quite different to what's happened before. It's not a closed shop. This is a community of not only clinicians who are not going to leave you behind. We need people on the coalface bringing their sort of the basic day-to-day problems to us, as well as working with the technical people who are there listening to this to work together to move forward. So this is different to what's occurred before. This is not a closed shop, smartest people in the room where you don't know what you're talking about. This is project really needing people at the coalface who have real problems every single day, who are just sort of accepting it now virtually and often very, very cynical about the difficulty they have trying to use their systems and just try and do their best to provide care for their patients despite it.
And what about the clinical information system providers? If I assume that they're not already participating in Spark, and I hope they are, what would you both say about their involvement? Is it a case of, hey guys, this bus is leaving town, you better jump on?
Absolutely. And that's why I think they're there. They've realised that all the big vendors that I've seen are there, and it's great to see them working and talking together. People have finally realised that this is going to be forced on them if it's not accepted. So we might as well get in and develop it in a way that works for them as well as for us. If they aren't prepared to get involved, then they're going to lose their market share.
I think Rob's correct. The negative part, and I suppose providers need to understand, is that decisions are going to be made by people that turn up. If it's a large community that's going to make it, there's going to be a mandate based on the clinicians and the number of providers getting involved. And you may miss the bus along the way, which may mean that, in fact, that the relevance of the software you're providing is going to become less viable for many clinicians and may affect market share, for example. But there's a positive there, and I've got to flip it around a little bit, because the one thing I've really heard, which I had never heard before, I always used to hear about how it was always competing versus another provider. What I've heard recently is this sense, and I think COVID has really jolted people into this, that first up, we need to do it for the Australian community. But also beyond that, there is this other aspect, which is that the innovation will come on top of being connected, not in spite of the fact that we're not connected, and that you can build on top of this, rather than thinking that, we're just going to continue to build in our own silo, remain in our own silo and kind of try and beat the rest. So there is that positive aspect, which I've heard, which I've actually been hearing it from providers, and we kind of need to move into that phase now for the sake of the Australian community and, frankly, my mental health and Rob's mental health, I suspect, because we've been around this for so long now and it's time to do it.
And what are some of the moments being part of the Spark community that have stood out for you, Rob? Is there any particular conversation or breakthrough or insight that has struck you?
It's going to the meetings. I can think of two recent clinicians who only in the last month have attended a workshop and come out thinking, wow, this is just amazing. This is fun and exciting and the potential is huge. And that's what's really struck me, is it's not just the nerdy people like Chris and myself who've been involved in this for 20 to 30 years. It's new people coming into it going, wow, there's so much potential here. And we had no idea, because you're so busy with your head down in the trenches that you don't realise that there's other opportunities to do things a different way.
Fantastic. Well, you don't often hear fun and exciting out of your continuing medical education sessions. You heard it here first. Terrific insight. The interoperability journey is an opportunity to put the patient at the heart of that and make sure that their care pathway has them at the centre as it should be. We've got an obligation to fix that.
Well, then it makes that communication so much simpler and easier. You don't have to do anything special. The clinician's got to write notes anyway in a consultation in the hospital or in the general practice. And if that information is shared or able to be shared, then the other person knows without having to find out, now, where is it going? Which doctor do they go and see? And how do I get it to them? Should I send them a fax? Should I send them an email? Should I send them a discharge summary? If it's all interoperable, it just should happen automatically.
Could I jump in there and just say that I had a personal experience and this hardened my heart to the whole thing. Bottom line is that the lack of interoperability, that means that the systems are not talking with each other and that critical patient data is stuck in each system and can't be accessed when it needs, cost lives. The thing that focused my mind was a very close family member developed septicemia, a young person. Basically, she was near death. Her blood pressure was down to 60 or nothing, and the ICU consultant standing there going, we've run out of medications, and they're throwing antibiotics at her, trying to revive her. And she actually made it. But they were very lucky because they didn't give her one medication, one antibiotic, which she was allergic to. Had they given it to her, she probably would have died at that point. And that was luck. But what it said was that, the inability of that ICU consultant to, at that moment, have the critical information they needed to make the right clinical decision put my family member at risk. And that really hardened my heart to this, that we really need to get to that point. It's absolutely crazy that we are in this position where the information is available, but it can't get to where it wants to, which is exactly what Rob's saying. We have the information, it isn't there when we need it, and it does cost lives. I was extremely lucky in my own family situation, but I'm sure that other situations, it's essentially Russian roulette and they have missed out and they've got the wrong medicine and it's possibly cost them lives or cost them a very bad clinical result. And that is why we need to move forward. It's time.
The Spark podcast is brought to you by the Australian Federal Department of Health and Aged Care, CSIRO's Australian eHealth Research Centre, HL7 Australia, and the Australian Digital Health Agency. You can join the community by heading to sparked.csiro.au. And don't forget to join us on LinkedIn at SparkedAU. This show is hosted by me, Brett Sutton, Director of Health and Biosecurity at CSIRO, and produced by Ed Studios' Janine Hamer and Lucy Ratz, and CSIRO's Dr. Naomi Stecklenburg. Sound by Hayley Dell.